This sitting is resumed. Prior to the suspension, we were in Standing Finance Committee. We return to the Standing Finance Committee.
This House is in Standing Finance Committee. When the House was suspended, we were on Head 86, Ministry of Health and Wellness. To this we shall revert. Honourable Member for St. Michael, South Central.
Thank you very much, Mr. Chairman. I have 3 questions in my first round of questioning. These are very simple and straightforward. Some of them were touched on by the ministers and their teams earlier, except I'm asking for a little bit more specificity. Let me start with 2 issues that are critical for the government of Barbados, or that have been, especially with respect to the Barbados Economic Recovery and Transformation Plan. Under the BERT program, under the BERT plan, the government and its statutory, state-owned enterprises, statutory institutions are not to accumulate arrears. Now, the accumulation of arrears is an issue of financial governance, is one of the reasons that we had these arrears targets under the BERT plan. But it's also an issue of small business growth and development, because we know well that a business that has outstanding receivables is also not able to reinvest those resources in growing and in its general day-to-day operations. So I ask this question from the perspective of not just meeting our requirements under the BERT plan, but also making sure that we are true to our word when we talk about supporting small business. And it is this. There are many people who have reached out, not just in my capacity as a member of parliament, but also in terms of what they see as my association or former association with the Ministry of Finance and with Economic Matters. And their concern has been the issue of their own receivables from the Queen Elizabeth Hospital. So these are providers to the Queen Elizabeth Hospital supplying essential goods and services, who themselves have issues with their own cash flow and with their own reinvestment in their companies because they have outstanding receivables from the Queen Elizabeth Hospital. And before the minister comes back in to repeat the issue of scarce resources, I want to emphasize that this is not a question of the quantum of resources. This is a question of the financial and economic governance of the QEH, and making sure that the cash flow matches and the financial management matches your commitments. So I would like to hear a bit about what are the challenges there. I would like to hear a bit about how that is going to be resolved in this financial year. I hear us talking about things that we are looking at and things that we are considering, but I want to remind us all in this honourable chamber, if I can, through you, Chair, that we are looking at the estimates of revenue and expenditure for the year 2022 to 2023. We are discussing what we are executing in this financial year, and so related to that, not just the issue of receivables from the QEH that are outstanding as a perpetual issue, but I would also want to hear quickly what is the CapEx, what part of that 125 million that is allocated under subprogram 375 for the QEH, what part of that is CapEx in this financial year, and what is it going to be spent on? Thanks.
Thank you, Honourable Member. And I do agree with you. The BERT program stipulates that we must not carry any payables beyond the agreed time frame. In respect of the Queen Elizabeth Hospital, the Queen Elizabeth Hospital receives a transfer from the central government, as I indicated, the next financial year, of approximately 125 million, up 5 million from the 120 in this financial year. The second issue is that the Queen Elizabeth Hospital benefits from the health service levy. I think when we look at the projections, it would have been upwards of about $55 million that we're projecting to gain in this financial year. Obviously, with increased economic activity in the forthcoming financial year, we presume that we can get back to maybe above the 55, maybe hopefully $60 million, obviously depending on the level of activity out there. Other revenue from the Queen Elizabeth Hospital amounts to approximately $3.1 million in this current financial year. When you sum that total, you're talking about just approximately about $183 million. Now, with $183 million, currently when I review the hospital's P&L, the hospital funding requirements are approximately in excess of $200 million. So before we do anything within the financial year and the forthcoming financial year, we will be looking at a deficit. Now that has implications for cash flow, and therefore the accounts payable at the Queen Elizabeth Hospital will always be a difficult exercise to manage. Having said that, we have to look and put our financial brains to work in an attempt to address the situation. How are we going to address the situation? We have to, first of all, secure additional funding for capital expenditure. We can't look at the 125 million to carve out any of that specifically for a 5-year or annualized capital expenditure plan. Because at the Queen Elizabeth Hospital, 70% of whatever is required is allocated to labor costs. So you start at a position where 70% is labor costs, and then you have to look at the other operating costs and utilities, etc. So in summary, we want to improve the accounts payable situation at the Queen Elizabeth Hospital. That can be assisted if we request supplementary funding from the government, and we can get that supplementary funding. If we can't get the supplementary funding, because we know that there are other government departments making a call on the consolidated fund, we have then to look at other income. And in the forthcoming financial year, we have to get back to a situation as obtained in the past, where the Queen Elizabeth Hospital was able to rake in at least $12 million in other revenue. And we now have to devise strategies to ensure we can enhance other revenues. Now, we also have a situation whereby there are persons who have healthcare insurance. And what I think we should do is we should have a situation at the Queen Elizabeth Hospital that encourages persons who have healthcare insurance to apply that healthcare portion to assist the Queen Elizabeth Hospital with their revenue enhancement position. And I think that if we can get that done, I think we'll be in a better position. But I can't guarantee that in the next financial year that we will not be in a position to pay all the payables unless we start that gradual process of improving other income and improving other income as they did in the past, like I said. But we also have to start thinking about out-of-the-box commercial approaches. If we get a capital expenditure program approved, and we are able to reduce some of the recurrent expenditure that we have on, maintaining equipment that perhaps ought to be replaced some years ago, if we can start looking at other efficiencies. But I warrant to you that along with Minister Brown, Dr. Brown, that we'll be paying acute attention, and we are going to be putting all of our commercial and medical skills to work to hopefully bring this situation under some level of control. As I indicated in my opening remarks, the heads of departments will have to account for their spend, and we're going to have to be very judicious about that. The hospital is no different from a hospitality environment. It has occupancy, it has other costs, and we're going to have to start reviewing the costs, all costs, within the Queen Elizabeth Hospital to see how best we can create a more efficient management system. So I will endeavor. I can't tell you that we will accomplish and pay everybody before the end of the financial year, but certainly what we will do is not to violate the BERT program in the first instance, but we will try to seek out other revenue, other income for the Queen Elizabeth Hospital as we move to improve the standing of the Queen Elizabeth Hospital in the public side. Thank you.
Thank you. Thank you, Minister. I didn't hear a CapEx number that you're targeting for this year, but I do hear you that some of your decision-making seems to be a bit fluid in that regard. I'm happy to hear that you intend to settle the issues of financial management. Just to say quickly that based on some of my conversations with the small business sector, with the business sector really, I think that these matters are urgent. If we consider that these are companies that are supplying, in many cases, medical goods and services, we will then have to hope that they're able to sustain their good faith relationship with the government of Barbados or with the QEH, because the moment that they make a decision based only on their own profit or their own business decision making, then the people of Barbados will be in a bad position. So I just encourage us to try to be able to settle those issues because these are companies that need to prosper and grow just like anybody else. I'll move quickly to my second question, which is straightforward. We said a lot about surgical wait times for surgery and other and some non-surgical procedures, but I didn't hear much about clinical wait times. So this is to say that people who are referred from polyclinics, for example, people who just need to be seen by a specialist, what is happening is that appointments are postponed sometimes for an entire quarter, sometimes for 6 months. And these are people who have urgent issues, who in some cases are waiting for confirmation of a diagnosis that is potentially very serious. And you would understand that it would seem often to the patient as if these are kind of ad hoc decisions. So the person, it might appear, and please do correct me, I hope you will, that a person is looking at an appointment book and saying, well, I know that I do not have a clinician for this time. I have no idea what this person's issue is. I have no idea the severity or the urgency, but I'm just managing an appointment book, and so I shift this 6 months down the road. So I've heard the full explanation about surgical procedures, including cataracts, et cetera, but I want to hear something about what is happening, what is behind this issue with people who are being referred just to be able to have a consultation, and their appointments are being delayed and delayed. And I dare say that in some situations, they're delayed to the point where they're no longer of use to that individual, because by that time it is frankly too late.
Thank you, Minister. Good. Put it this way, we have been, within less than 5 weeks, we've been going through and reviewing operations at the Queen Elizabeth Hospital. We are looking at the outpatient clinics and how best we can improve the outpatient clinics. The other thing I would say is that the status quo at the Queen Elizabeth Hospital will have to change. We are going to have to look very carefully at how we deliver services and how we manage appointments. We have, and Minister Dr. Brown is currently leading a team to look at a new medical electronic medical records electronic system, which we hope to have in place soonest. But beyond that, the service delivery, and I think that's what you're hinting at, we have to improve it. The way to improve it will obviously will require us to engage in continued dialogue with the consultants, the physicians, and other persons at management at the Queen Elizabeth Hospital to make it happen. But what I would like to do before I come back to you is allow Dr. Clyde Cave, who's who's the Director of Medical Services at the Queen Elizabeth Hospital, to respond to you, and I'll come back, Minister. Sorry, Honourable Member.
Good afternoon. Dr. Clyde Cave, Acting Director of Medical Services. Thank you for the question, because our medical outpatient clinic has been one of our services that has had the most important and profound impact from COVID. To specifically talk to new appointments, which was a part of your question, all new appointments are supposed to be reviewed by a consultant and the appropriateness of the timing of the first appointment made. Subsequent appointments are handled by the house staff, and this is one area where we have employed telemedicine, which mostly is telephone contact. This really worked better when the country was under more severe shutdown. As we opened up more, having telephone contact with patients during working hours became more difficult. Our plans going forward is, as we have the return of our staff who have been deployed from the isolation centers back into the Department of Internal Medicine, these outpatient clinics should be revitalized. We are going to keep telemedicine as one of the arms, but we are considering extended hours of operation, and if funding allows, some of the private practitioners who assisted us in keeping the clinics going, they may be retained in a specialist capacity. Thank you.
What I would also like to add is that we're also reviewing operations of our outpatient clinics. I would have alluded to this earlier. We're looking to see if we can build out additional clinical space at the Queen Elizabeth Hospital. And if we do that, we're going to look and see how best we can either retrofit a space or acquire a new space in order to enhance delivery of patient care. Thanks, Honourable Member.
Thank you. My final question relates to the earlier conversation that took place on chronic NCDs. I recall that around 2018, we had quite a bit of conversation on specific programs or incentives for certain certain behaviors related to the management of people's health. One of those ideas that we developed had to do with this notion of a wealth for health approach, which is that you actually have, because of when you compare the high costs of care, of healthcare, particularly in this area, what we noticed, what we realized was that it would actually be more cost-effective and more efficient to offer certain kinds of individual incentives for certain kinds of behavior. And we discussed programs where people would perhaps wear something that is a watch, one of these smart watches that allows us and them to track certain behavior, to track their own compliance with drug and other treatment protocols, to track their diet and their activity, and to be able to locate that within an incentive program. And in lots of jurisdictions where it was tried, it worked very well, and it was actually more cost effective to the government. Similarly, a kind of conditional cash transfer within the social protection system, where people who are benefiting from certain kinds of cash transfers would also then need to be able to, and who are patients of the healthcare system, would also then need to to show certain level of compliance, not with burdensome things, but with the regular day-to-day actions that they have to take to secure their own health. I know similarly that the question of the cardiac care project also was around since 2018, and I'm hoping that we will now get some specific outcomes and timelines around that, because we have been hearing for some time what is planned, but I fear that we are not seeing what are the outcomes of that. But I wanted to ask specifically whether there is a concrete plan to use these kinds of incentive programs, not just to think about them, but to see whether there is scope to implement even on a smaller scale to start, because I do think that we have to start moving towards some concrete actions in this area. So I wanted to hear a bit about whether any such approach was going to be planned. There's much more that I could say about some of the approaches to these issues of people's behavior and how we frame things like childhood obesity, because I think that sometimes in the framing of these issues, we stigmatize the state of being obese rather than the underlying factors that have led to it. This is not the forum for me to go on these things, but I do think that when it comes to issues of how we approach labeling, how we frame some of these issues, that there's a lot of scope for us to perhaps review or tap. But I want to hear, please, if I can, about whether there are concrete incentives programs that are linked to that are linked to individual incentives or that are linked to cash transfers that can help us in this area.
Thank you, Honourable Member. And before we go there, I think it will be useful to have an intervention both from Dr. Clyde Cave and also Dr. Arthur Phillips. But before we go there, I think that you will be aware that the government in the current financial year would have started a community health worker program. And that program is meant to help us with the management of NCDs as well, which would effectively lower costs at not only the Community Hospital, but also other public health institutions. But before I go further, I would ask Dr. Clyde Cave and also Dr. Arthur Phillips to have a discourse on this matter. Dr. Cave.
Thank you, Clyde Cave, Acting Director of Medical Services. And thank you for this question, because the Transitional Community Care Program is one of the very few new clinically based programs that we have been able to implement during COVID that is not specifically COVID. Thank you very much to the Prime Minister who shepherded this program through by giving us a budget to run it as a pilot program. Now, to specifically address your concerns, there are many target populations of vulnerable people, and the population for this program is those patients who are already patients at the Queen Elizabeth Hospital with a chronic disease, mostly diabetes or cardiovascular disease, specifically heart failure. As the program, which was in operation for a year, has evolved, we have expanded to increase some patients who have amputations or wounds that need addressing, and also some patients who we have had to discharge from hospital perhaps sooner than we would want. So this population are the patients who are our frequent returnees and attendants at our outpatients and the accident and emergency department. So the concept for this program was to develop a cadre of healthcare workers who can visit them in their home and, in liaison with their managing consultants at the hospital, implement the treatment, monitor the treatment, help educate further the patients and their families, assist in nutrition, exercise, and as you have said, encourage them to become invested in their own care. Many of these are older patients with chronic conditions, so the usual didactic kind of teaching doesn't work. This inpatient approach works very well. And from the first year, it is really encouraging to see that this program has borne fruit. Initially, because it's a new program, we had to invest quite heavily in the design of the program in collaboration with the George Eileen Chronic Disease Research Center and Professor Simon Anderson to build in monitoring indices where not only could it monitor the success of the program, but it would allow it to be publishable. And what we have found in the first year, where we have onboarded nearly 600 of these vulnerable frequent flyer patients, in that the exclusive visits to the accident and emergency department, which used to be very high, they used A&E as an outpatient clinic. Those decreased to 26 only visits that were not part of a planned readmission or reassessment. And for those visits, they are accompanied by their designated healthcare worker who knows them. One of the other KPIs, the performance indicators built in, was readmission to hospital within 30 days of discharge. And for the nearly 600 of these highly vulnerable patients, there were only 4 admissions within 30 days of discharge. In my view, this is an incredible achievement, for not only will it increase the quality of care of these vulnerable patients and address the deficit in secondary care, which we have always known exists, but it really does help markedly reduce the burden on our accident and emergency department from these patients who really took up a lot of time and resources. Thank you.
I'll ask Dr. Arthur Phillips to come and weigh in on this issue as well.
Good afternoon. Thank you, MP Cattle, for the question in relation to the health grants and incentivizing healthy behavior. Absolutely agree, as you would have mentioned, that the causes of NCDs go way beyond the clinical issues and sometimes even the simple issues around individual behavior to the wider issues of the supportive environment. And one of the ways in which the environment can be supportive is by incentivizing the sorts of behaviors that we would want to see that would reduce the risk of developing NCDs and reduce the risk of progressing once NCDs have been developed. One of the concepts that we speak about when we speak about health and NCDs is the idea of social determinants and the reality that individuals' behavior is shaped by their environment, their financial, their physical, and other aspects of the environment. There is some evidence, as you would have mentioned, of incentives positively impacting individuals' behavior. And certainly, we've seen physical activity, healthy nutrition, and other aspects of NCD prevention promoted by use of incentives either at the individual level or at the level of healthcare providers who are interacting and engaged in preventive interventions. There have been some efforts in the past to provide tax concessions for individuals undertaking preventive procedures.